New unit. Thank you. We're starting a new unit on skin. That was noisy. Turn that down. You can tell. Oh my word. So I loaded a couple of things. I'll show you right now. Here we are. So your the textbook's PowerPoint is this one on skin. It's a little out of order. What's interesting about that, they put conjunctivitis as a skin. And I understand the logic they're doing this with eye issues being effectively surface and extension of skin. That's a matter of I like it the other way with regard to respiratory. That's just me. It won't be a big deal because it covers the same information. So their PowerPoint on skin is 16. I'm going to use this and reflect back on the other one. I did comment. And if you want to take a look at this, go ahead. I'll give you some idea. All the COVID information you need, I presented to you already. This gives you some of their idea on COVID from respiratory. If you're interested in it, go ahead and take a look at it. I wanted to do it for the sake of completeness. I think that's important. I do have an outline on this that you'll be able to see if you take a look. Let me move this out of the way. Thank you. And so you can see this, all of these different things, viral, I mean, the same thing, viral, bacterial. It's not a terribly long one. That's just a couple of pages that are there, but it will be a little more extensive than that, I am sure, with what we have to cover. So I would, the size or lack thereof of the outline is not necessarily what this is all about. Also, in this, it has been reclassified, but I've always felt it was skin because the major manifestation of it to start is on the skin, the identifier, and that's what we'll talk about Lyme disease. Right now, Lyme disease effectively is classified as an immunological disease because the major way it affects you is by way of your immune system. We'll get through all of that, but nevertheless, the introductory nugget, always fun. This is, if you're, interestingly enough, he discovered and named after himself. They always do, and unfortunately died. Okay, Rocky Mountain spotted fever. And interestingly enough, it would be more common here because it is a tick-borne illness. Both of these, as is, and I mentioned Lyme disease, so ticks are bad to get in contact with you. Here's one that's a louse-borne disease in Mexico called typhus, which has an interesting history of itself. And again, they named them years ago, these tiny gram negatives that were growing inside the bloodstream and were intracellular agents. When I was learning about them, they said, we don't even know where rickettsia are. We didn't have the technology to be able to identify them as tiny gram negative rods that were intracellular. They were like another category. So interestingly, now we know what they are. Okay, very, very hard to grow. Okay, and really it was all about, when we learned about ticks, they said, oh, this is tick-borne paralysis or tick-borne diseases. We really didn't know a lot about them now. And again, my class of microbiology was more than 50 years ago, so it gives you an idea how the technology has changed over that time. So nevertheless, they have great names that you're not going to necessarily have to know. I'm just starting with the introductory stuff. I couldn't wait for you. You hardly have any food.
Listen, you're fine. We ate in Romo's. That's why.
Oh, thank you. Gee, Dr. Stein, would you like a cup of coffee? No. Maybe a tiny little morsel to eat? No.
I ate it all.
TAFOL. Thanks, AF a lot. Yeah, same to you, buddy. And I told my wife how nice the students were, which I should have been more honest and forthright with her. So I have coffee. It's okay. It's okay. Gotta watch my girlish figure. Not that funny. It's okay. So I met up with my daughter briefly on her way to a relatively fancy restaurant. She goes, gee, Dad, you look good. I said, oh, thanks. It's my daughter's eyes. I give up. Okay, skin. We know The skin is the strongest barrier to infectious disease. It doesn't preclude there being problems, and the injury, and usually it has to do with something that has somehow gotten through this major barrier. So all of those are inherently obvious. Any times of chemical injuries, thermal injuries, cuts, punctures, however you want to classify them. And even little openings, particularly sweat glands and sebaceous glands, those hair follicles, those are all potential points of entry all the time. So, and any of these things, and interestingly, this is indeed the problem. They'll be able to enter and get into the bloodstream. So all of these things we know about what skin does. I don't want to talk about. We'll talk about skin-associated lymphoid tissue and sensation. That was in our anatomy and physiology skin unit ages ago, as was this. So we're not going to go over any of that stuff. You don't have to know it. Okay, I mean, that's part of the stuff. I say you don't have to know it. It's something you should already be familiar with. A better way to express it. So if I'm asking you a question about that, that's that old, basically a prerequisite kind of knowledge that you have to have if you got through anatomy and physiology. So, and we know about perspiration, the salty residue, and the oily sebum, water repellent, nice and soft. Okay, and certain microbes you're going to see. We're going to talk about normal flora. So most of the time, okay, all of these things doesn't work for a lot of pathogens. Unfortunately, this is where Staphylococcus comes in. It's normal on your skin, and we're shedding all the time dead skin cells, and indeed they're laden with microorganisms. They got plenty of them, and the normal flora are not necessarily part of the problem. I mean, these are just interesting. We begin to understand when somebody has body odor. I mean, some people are genetically more predisposed to it for whatever reason, the bacteria and the nature of the oily nature of their particular perspiration. It's not always hygiene. And I think that's a misconception a lot of people have. Hygiene can certainly be a cause of it, but it's not only a cause of it. So, and it's different, and it's always, these are the areas. We call them intertriginous. It's a fancy name for where skin rubs against skin because moisture gets trapped. And if there's a common denominator of problems with skin, it's moisture. Many of you are going to see this in the clinical environment. You're going to run into people who have, these are the areas you really have to be, where skin rubs against skin. It's a significant problem. All of these types of areas, you can see, look at the numbers, they're staggering. How many orders of the power of 10? I mean, 1,000 is 10 to the third. 10 million is 10 to the seventh. That's 4 orders of exponential magnitude, powers of 10. That's a big deal. These are some of the things you might have seen if you did little skin samples and did them in the lab. A variety of different organisms are there. I mean, we can go crazy with it. Diphtheroids, gram-positive rods that are non-endospore formers. This is a natural area for Staphylococcus. Staphylococcus epidermidis. And it's a big player in the infections we really are concerned about from the hospital. Why is this here, and why didn't they? Specialization, but I'm sorry. Please don't erase. Don't leave it here. And don't lock the door. Do this. I'm not angry. It's just a certain amount of consideration, which will be very important. But on all of our skin, all the time, and a real nasty bacteria in those who are compromised hosts, which is what you see in the hospital, Staphylococcus epidermidis. It's on 100% of our skin, 100% of the time. Along with the diphtheroids, along with this guy, there's a particular fungus that's very common. It's got, I love the names of fungi. This is called, it's pronounced Malassezia. And it grows, again, in areas where there's a lot of oil. And its last name, I always misspell. Here's the Malassezia, and its last name, I love it. Perfer. They have great names. Perfer. And it causes something that's very interesting. When we talk about fungal infections of the skin surface, they're called tinea, like tinea pedis is athlete's foot, tinea cruris, crural areas like this, quote unquote jock itch, with tinea in the axis. There's all sorts of names. This one causes tinea versicolor. And that's something to look for. I've had students who have had this. It's really the only thing you can do is topical of it. And the way you identify it is use ultraviolet light. And versicolor means when you shine ultraviolet, it's just an ultraviolet examining light. It's got a fancy name called Woods light. It's one frequency, so it's not dangerous. It's called Woods' light, particular ultraviolet light frequency. We use it all the time clinically, and it demonstrates a certain, and it's multiple colors. That's why it's not just one particular. It's a very useful tool in dermatology. It's the old story. I don't know a lot about a lot of things, but I know a fair amount. I'm pretty good with dermatology. But I saw a lot of it. So moving on. So here, point of thing, acne. We have the burgeoning amount of sebum at the base of every single hair follicle on your body. It enlarges, and in certain individuals, it gets trapped. And when it gets trapped, we end up with what we call blackheads and whiteheads. This is now the name. We used to be Propionibacterium. It's a dipteroid. Now it's called Cutibacterium acnes. Gram-positive rods, anaerobic because they get trapped in there. And when they get trapped, they use the sebum as a nutrient source. And again, certain people are more predisposed to it than others. I mean, it's an ongoing problem. We're always going to have difficulty. Again, I think there's a hereditary part of it. There's a lot of good ways to treat it, and many of them are very successful. So I don't want to make the course about treating acne and things like that. I mean, that's something that's always been an ongoing thing. There's a lot of commercial products that are good. Most of them are variations of vitamin A acid. So they're trying to expose the area and maybe even to some extent super oxygenate it to a certain extent as part of the treatment that's there. The interesting medicine that's used in very severe cases that many of you might arguably know somebody that's it's called Accutane. You know, folks who have used that over the years. Very interesting. It's like super high activity vitamin A acid. The good news is it works. The bad news is it has a lot of side effects. My stepdaughter was on that because she had bad acne over the years, and I mean they would not give her. They had to. Maybe I told you. She had to have a blood test done at the hospital up by us in Cranberry, and that blood test had to be negative for pregnancy before the pharmacy, which happened to be up at Walmart in that same area, would let us get the prescription that day. And it also caused some serious suicidal ideations with people. There's a lot of interesting saga. If you look up Accutane, it's a pretty interesting medication, and many of you are going to become familiar with it when you take pharmacology. Just saying. So acne, metabolic progress, inflammatory response, abscesses. Okay, most people have it on their skin throughout their lives. Certainly puberty and the onset, that tends to be where it is. Typically, yeah, this is the mistake people make. It should be treated and understand how to treat it appropriately that are there. And so it kind of goes into the area, and this is, I mean, it's sort of a subset to me of folliculitis. So the hair, it gets into the hair follicle area. But in general, this is what we see more than anything else. Common infections start with hair follicles. Most of the time, they're nothing more than a pimple or a pustule that we can allow to open by themselves. Or superficial. Moist heat, topical antibiotics, anything along those lines is probably fairly effective at using it. The big problem is if it doesn't get to the surface, if it's deep and gets trapped, that's what brings about, and the fancy name is called furuncle, but you and I typically call it a boil. And boils, the problem is you have an abscess underneath the skin that just is not going to come out without assistance, and that assistance basically means something we call incision and drainage. And incision and drainage is just that. You incise it and you open it up and allow all the bad stuff to come out. That's a very standard treatment for abscesses, and really that classifies in that particular area. It's not necessarily pleasant. The ones that are really nasty are these. They're called carbuncles. Okay, and so this is when you get a cluster of these that become infected in an area, and you really have to open those up. Typically, you have to do these with almost in an operation type of a scenario, and they have to be packed so they heal. When it comes to healing things on the skin, because I have consideration for the next teachers that we get. Do not erase the long road. Yeah. Not that funny. I'm gonna erase it right now. I don't care what Dylan says, or agree or wrong. And if you know that, tell them, take a picture. Next time. If you have something in the skin, you don't want it to heal. The reason we don't sew these things is you want them to heal. Things from the skin heal from the bottom up. And they come in, and new cells come in from the side. So what you don't want to do is have one of these things and get it to close over prematurely. You almost intentionally want to leave it open. That's why we pack those or leave things wide open. And we allow them to heal, because what will happen, the fluid will get trapped in here, and you'll generate a worse kind of infection. So the microorganisms get trapped. We want to provide them with a way out, and we want to provide the skin cells with a way in. This, I even go over this a little bit. We do wound healing. It's the same kind of a phenomenon. It's there. So having done so much of that over the years, I'm trying to share you an idea of what with you, the idea of where this is. So a lot of times you're going to see things. Another thing that people get is called a pilonidal cyst. Have you heard that before? Typically that's associated in the lower back, sort of in the area where the upper portion of the butt cheeks are. And those hairs get trapped in there and they form a cyst. Generally that has to be drained surgically. I mean, it may just be nothing more than a local anesthetic and draining it out and packing it and having, either having someone at home, a partner, a parent, or whatever, being able to help out with that, depending on the age of the person that's involved. Okay? So the big player you already know about. Did you do the coag test in lab? Okay. Coagulase is plasma. One of the nastiness factor of Staphylococcus aureus. And back in the day, we didn't say staph epidermidis or staph aureus. It just said staph coag positive or staph coag negative. And that was for the enzyme coagulase. Coagulase is produced, and what it does on a slide, it causes clumping. And so what it does biologically in a Staphylococcal aureus infection, it walls it off and doesn't allow your immunological response, your white blood cells, etc., your antibodies to get there and attack it. So it's almost like creating a barrier that prevents your defenses from getting here, which is really a net. So this is one of those real high-level nastiness factors. There's more than one, but coagulase is the one. And what we have in the lab, we probably have some little vials, if we're still using them. Again, I haven't done the lab in a while. And what you do is you reconstitute the plasma. They use rabbit plasma. It's freeze-dried. You put a little bit of sterile broth or sterile water in there, and you take a little bit of that in a sterile pipette and you put it into a tube and you inoculate the tube and let it sit in the incubator overnight. And if it turns solid or forms a big gel, that's coag positive. If it stays liquid, it's coag negative. Are you guys doing unknowns in lab? Yes? That would be a test to be, you can do the coagulase test if they have the plasma. I'll even go in and look at the lab to make sure. Mrs. Maurer would certainly know. Dr. Dress should certainly know. See? You learn something new every day. Help me. Other little nastiness things. Food poisoning. Staphylococcus is probably, if you get food poisoning of a dairy origin, most likely it's staphylococcal, by the way. So that if you get something that's a little, if the milk is a little shaky, or the dairy that's used in the recipe is a little shaky, it's one of those things when that it's family reunion time, right? Coming up. That one where they put out, hey, you gotta leave that stuff on the ice. If you don't, if it's got like a dairy component, like a creamy kind of a component, make sure it's on ice. Because if not, grandma's famous potato salad or coleslaw might do you in, or at least make you fairly sick. It's unlikely to kill you. Just saying. All the hair follicle infections. Here's a nasty one, impetigo. Impetigo is interesting. They should have a pretty good picture of this. I mentioned it before with streptococcus. You remember me talking about the streptococcal skin infections called impetigo? It forms, it's on the skin. It's got like a golden yellow kind of a plasma that's associated, so it's easily identifiable, as opposed to just a tiny pustule or something like that. It's got a more distinctive color. If it's staphylococcal, it's relatively easy to treat. It's not usually a MRSA type staph. If it's streptococcal, that's the one you really want to make sure you treat because of the strong association with kidney problems, particularly one called acute glomerulonephritis, which you saw in the respiratory presentation, but I think it's more common in the skin than respiratory, though it occurs in both. Damage to heart valves. Scalded skin syndrome. You'll see this. It's got a very interesting name. We see this, unfortunately, it's the type of thing that's contagious enough that it will go through a nursery. If you're really interested in neonatology or maternal child, the name of this toxin is called exfoliating because it's an exfoliating toxin. Imagine it's like a baby without getting burned. It looks like almost second-degree burns over the whole body. Sandpaper rough, it's extraordinarily painful, and the real problems are fluid electrolyte loss, which it is anytime you have something that's causing your skin, the outer layers, to shed, just like they would in a second-degree burn. So this is another thing, and that's caused by that staphylococcal scalded skin syndrome. Toxic shock. We'll look at this in wound infections and genitourinary infections. Streptococcus, much more common staphylococcal in origin. We typically see this from injection sites rather than the tampons, which were originally associated with it, and it's public enemy number one when it comes to wounds. I have a very interesting wound outline from the chapter that's in this textbook, which is sort of married a little bit to the experience I had with wounds, and I have a ton with that as well. Just saying, not patting myself on the back. From what I did, I should have that. And so I strained my arm recently patting myself on the back. Other than the food jokes, could somebody smile occasionally? You're awful. What did you do? You got to stop partying all weekend. And I'm looking at you. I'm particularly looking at her. Got to stop. The trio, yes. You got to stop. Look at this. Where it can all go. Hair follicles, injuries, all of these types of things. Abscesses, all of those infections enter the bloodstream, and then it's real trouble. So this is kind of what it looks like to start. This would be a typical start of one. Typically, that would open up with just warm, moist heat. Okay, warm, moist compresses, something topical on it, topical antibiotic, most likely to open by itself. You don't want to go squeezing these things. Please tell people not to do that. But the problem is, if it goes deeper, then you have to open it secondarily. A number of virulence factors. Ones that will inhibit phagocytosis, disguise it, a variety of enzymes, just like coagulase, a lot of toxins. It is nasty, and that's from hair follicles. Sometimes they'll be encapsulated. The coagulase, and I think clumping factor to a lesser extent. This may slow the progress of leukocytes, etc. Food poisoning, exfoliating, outer layers of the epidermis, and goes on and on. Spreading factors, toxic shock. They are not all in one strain. There's so many different strains, and we haven't even talked about the evolution of this to MRSA, where now we have a difficult time dealing with it with antibiotics. I can't emphasize it enough. It's there. You can see these types of things. Again, when we look at a cocci, we don't see all this stuff that's sticking out of it. We don't understand. I mean, that's the wrong term. It's hard to appreciate when you see this little ball under the microscope, just like streptococcus, what could be protruding from it, but it's what's protruding from it that causes the problem, along with what it secretes or gives off that are there. 30% of healthy adults carry it continuously, 60% more about. And when it comes to MRSA, I said it before, at least twice a year, people in healthcare are cultivating MRSA. You can't help it. You're exposed to it in that area. It's a normal place where it grows is right in your nose. And typically, again, we cough, we sneeze, you're doing this. Next thing you know, it's on your hands. And all you can say is hand washing, hand washing, hand washing. Sometimes it's shed more than others. They survive very well in the environment. That's the big problem. Staphylococcus is one of those agents. It's got a fancy name. It's called a halophile. It likes salty environments. That's why you did it yourself. MSA is 7% salt in the agar. That salt is what makes it selective. Remember selective and differential plates? You also, did you have like quizzes about that stuff? So what does salt do? Salt excludes ones that don't like salty environments. I'm sorry. And your skin is like that. Fomites, it can easily be transmitted. All of these types of things that are there. The question are, what antibiotics will work? A lot of resistance to a lot of all the beta lactams is particularly developing with MRSA. All these other things we talked about, healthcare versus community acquired. Hospitals screen a lot of the patients. When you start to go work in the hospital, you're going to see people coming in, we have to do a quick nose swab. Well, why is that? We want to make sure you don't have MRSA. Basically, they're checking medical legally. That's code for, oops, if we get sued. If you brought MRSA with you, basically you can say, not our fault. I mean, understand that. That's part of it. So they did to me when I went into ICU back 20 years ago. That wasn't the infection I had. But yet I'm here to enlighten you about all of these things. I would love to see a little more bright smiling faces this morning. You are not day shift people. I can see that already. 3 to 11 for you. That's right. My wife loved it. She's got to sleep in. My first wife loved it. What does that say? Staff, this is an infant. Look what's going on. This is scalded skin. Okay, that's that exfoliate 5% of the strains that produce the toxin of Staphylococcus aureus. And unfortunately, it can spread. It starts with just redness and a little irritability. Very painful. Within 48 hours, it's just like the child, or particularly the infant, was exposed. And so it is really a management problem. Carried in the blood, widespread area, fluid loss, risk of secondary infection. That's the same thing when I talk to you about burns and the skin. Many of you in anatomy and physiology, nearly all of you, I would think, right? This is what we talked about. The two big problems with burns. Same deal, even though it's caused by a toxin rather than a thermal injury. Most frequently newborns, antibiotics, debridement, which is not fun, can be fatal. So it's very identifiable. Again, if you're working in the nursery, many of you might see that, because that's really the most common area for it, etc., etc. Treatment, and I think we're more likely, it's my recollection, that it is not necessarily a MRSA strain most of the time. This is the impetigo. Old time we called it pyoderma, which means pus of the skin. Okay, a lot of things could lead to this. Rather innocuous things, but this is a really good, because you begin to see this almost like a golden yellow kind of plasma that dries. Why is this not a cold sore? Where it starts. Cold sores start on mucous membranes. So it'd be lips, gums, cheeks. The skin of the genitalia is very, very different. It's very delicate. It is not nearly as the skin of your face. So if it starts on skin, impetigo. If it started here, like a bad cold sore and spread, that would be viral. That would be typically a herpes type 1 infection. Okay? That's the diagnostic nugget. So, so it's one of the questions, where did this start? You know, it started in here, now it seems to be all over. Most likely that's a cold sore. Gee, it started here and starting to spread to my lip. Impetigo. Be aware of that. More often than not, it's Streptococcus pyogenes, can also be staph. This is the one you worry about, the Streptococcus pyogenes, because of those clumps of antigen antibody complexes that get together, clogging your kidneys. Thin wall blisters, a couple of days, drying plasma, that's that sort of a golden yellow kind of a color, etc. And they talk about these things. I can go deeper. There's other virulence factors. This is the thing. Again, those post-streptococcal sequelae. You know, I mean, so many students over the years have come to me and said, you know, I had that as a kid and they had big problems with my kidneys. I had to be in the hospital for a couple of days. It's more common than you think. A table that just points to the different things that are there. Down the road, again with Streptococcus, as with both, with toxic shock for both, we'll talk about necrotizing fasciitis. That's probably going to be in our last week. I will send you the note about, I will open that, but I'll memorialize it in print. In other words, I'll send you an email. We're going to, for that thing you're doing on Blackboard, I'll open it probably 8 o'clock Thursday morning and, you know, probably close it sometime it'll close by the end of the day Thursday. Just so be on top of that. 1 hour once you hit the start button. And not that I would think any of you would be sitting next to each other, you know, with your cell phones or your computers. It scrambles the questions and the answers. So question, you might have question 1, you'll have question 6, and this might be, 1 might be A here, 1 might be D for you, 6 might be C. Get the idea? It does it. It's nice. You don't have to thank me. So please make sure you prepare. You should have been preparing already. Epidemiology, more common, unfortunately, hot, humid areas. I think the more common is when it has to do with socioeconomic status. It's a nice way of saying poor kids. It's maybe the lack of attention to healthcare, the absence of parents. Those are types of things that are part of it. The prevalence of insects and sanitary conditions. That's all part. I mean, that's always going to add to any kind of a situation. Be aware of it. Don't be judgmental. Everybody, I'm saying this to you right now. I will tell you a story on Lyme disease. We won't get to it today. It'll probably come to tomorrow. Where a very bright individual, ostensibly me, was a little too judgmental, and sometimes that can be a mistake. Don't think about it, because that can alter your. You need a degree of objectivity. So all the types of things there for treatment and prevention, you can see pretty straightforward. Antibiotics, topical care, etc. Thankfully, I doubt that you'll see it. It is more common than here than in the Rockies. If you look at where their outbreaks are, it just happened to be there where Ricketts was studying it. This is nasty. It's interesting. This is the rash classically starts on the extremities. Where a rash starts, it's one of those questions. Where did you get the rash? Did it start here and go that way? Did it start in your face and go this way? Did it start in your belly? Did it start in the extremities and begin to get closer to the torso? And then, depending on the location, whether it's a tick-prone area at certain times of year, that's when you may or may not see this. Okay, you don't see it on the palms and the soles. The fact, when you look at things like that, when you see pigmented lesions, are they flat? The fancy name for flat are called macules. This will benefit you going forward. When it begins to get raised a little bit, we call it papules. So oftentimes you'll see rashes that are classified as maculopapular. They're flat and sometimes raised. These are, we call these petechiae. Petechiae are tiny spots, purplish, reddish to purplish, tiny skin breaks down under the skin. So it's not really the skin, but it shows up on the skin. There's blood vessels under the skin. And oh boy, without treatment, is this extremely dangerous. Thankfully, antibiotics work pretty well. These intracellular parasites, these rickettsia, thankfully are very sensitive to antibiotics. You can't, again, things that you can't grow very easily are relatively easy to treat that are there. Gram negative, they have to live inside one of our cells. There's lots of ways to identify it. Okay, tick bite, and this is the trouble with ticks. The tick carries it from some other animal to you. So the tick is infected, and the animal dies. It jumps on you for a blood meal, and this is where it affects the lining of little blood vessels. That's why we see the rash, and then there's this massive inflammatory reaction that follows internally. Okay, and it gets into the bloodstream, and then goes all over the area, and that's why. And again, it's gram negative, so you have an endotoxin. So you end up with potentially shock. DIC is a very interesting thing. Did you learn about that at all in immunology? Disseminated intravascular coagulation. Gram negative sepsis. Where you might see this in C-section pregnancy, or a pregnancy that somebody terminated and didn't do it the right way, without getting into the ethics about that, or a ruptured tube, or a ruptured bowel. When gram appendicitis, gram negative sepsis, sometimes the toxins that triggers, and what it does is it gobbles up your clotting factors. And all of a sudden you see it starts with causing masses of clotting, and then it gobbles up clotting factors. It's a very unique disorder. The reason I'm familiar with it, my kids were little, we had a wonderful dog, giant golden. I mean, we're talking about 125, 150 pounds. The whole neighbor could come up and pet him. And unfortunately, he had some kind of a tumor internally, and when that ruptured whatever organ that was in the bowel, he got this. And I mean, when we took him to the vet, it was like, there's really nothing we can do. Now it's very difficult. So here, look at where it's sporadic throughout. Okay, we're an accidental host, meaning they jump on us when they're looking for a blood meal. Ticks are tiny. This is not the deer tick, it's a different tick. Okay? Just pointing that out to you. This is when it's active, starting now. You can see sporadically here, but notice the areas. It has a lot to do with sort of swampy, moist, very humid condition. Carolinas, Ozark area, Tennessee. So this is the area where we see most of the clusters that are there. Vibramycin or doxycycline is, and again, 20% without treatment, below 5% with. No vaccine, but it's usual. Tick precautions, tick repellents. Be very aware if you're going on a vacation or a trip. Again, this is relatively rare. The last chapter we looked at inhalation. Again, this is on the skin. That's there. This is called a necrotic eschar, ESCHAR, as you can see there. Necrotic for black. Nasty. Okay. Most of the time, the concern is if it would spread internally, or if you at the same time got respiratory. I'm sure I won't have a question about that. Bacillus anthracis, endospore former, black coal-like scab. That's where the name comes. Anthrax being a kind of coal that's there. Capsule and exotoxins. Okay, not likely if it's cutaneous. Again, this is people who work around animals and hides. Those are the ones who have this. Okay, and you have to spread from what you're doing. Again, like that wool sorter's disease, except rather than being cutaneous, rather than respiratory, and you can go through this easily enough. Is there? We'll stop it here because this starts the viral unit. So you'll see, just to give you the anticipation, that chickenpox and zoster, okay, shingles, rubiola for measles that are there. German measles are part of it. We'll look at some of the complications. We'll talk about the numbering system and warts. So there isn't a whole lot after this. I'll probably lead with, and I'll get you the chapter, the immunology chapter with Lyme disease. We'll start with that. Thank you very much. We got it all in, surprisingly.